My name is Ross Campbell. I'm a senior clinical lecturer at the University of Glasgow, and I'm also a consultant cardiologist at the Queen Elizabeth University Hospital in Glasgow. My background is in heart failure and also cardiac imaging, and particularly echocardiography and cardiac MRI. So this is very novel, so it's certainly not locally is it being used actively to diagnose heart failure. This is something that we are hoping will become something that can accelerate the diagnosis of heart failure and reduce some of the delays, but it's not actively being used in the diagnosis of heart failure currently in clinical practice really anywhere that I'm aware of. Yeah, so this study was looking to prospectively test whether the US2AI automated analysis, which was AI-assisted analysis and reporting of a handheld echocardiogram, would be comparable to a fuller cart-based echocardiogram, which we use in clinical practice. And we know that the US2AI model and reporting software and AI reporting the echocardiography is validated and it's FDA approved, but we wanted to prospectively test this in a real world population of patients with suspected heart failure. So that was the purpose of what we wanted to go and set out to do. So when we compared the handheld scan, and specifically the AI analysis of the handheld scan compared to the full cart-based scan analyzed by two independent sonographers, we found that the results of these different ways of measuring the handheld the scans, they were interchangeable. So the handheld scan had very similar results, and the proportion of patients where we could get a result was very high and very good. Like anything, we always learn things after the event. So one of the really good questions we got asked during the presentation is whether we changed the order of when we did the scan. So every patient had two scans. They had a handheld scan, and then they also had a full echocardiogram cart-based scan. And we protocolized doing the handheld scan first in our protocol, but actually in retrospect, perhaps it would have been nice to change the order, but that would have added extra complexity to the study. It would add a randomization step. So that's perhaps one of the things that we might have done differently, but I think even regardless of not doing that, we still have very good agreement between the two ways of assessing ejection fraction. So I think the clinical implications are that the two ways of assessing the ejection fraction, by the criteria that we pre-specified, are interchangeable. I think that in terms of clinical use, we now need to move on to the implementation. How does this fit into the clinical workflow? Does this actually accelerate workflow? We know it does work, but how does it work in the real world? So how does it work in the clinic? How does it work in a busy hospital setting? It has to accelerate workflow, and I think that there's great potential for accelerating workflow here. But that's a really interesting, area of clinical research that's ahead of all of us, is how do we take these exciting AI tools which have great promise and actually implement them and show that they are actually making it easier and faster to diagnose conditions and ultimately care for patients.